Right now.
Right. Hello, everyone. Good morning, good afternoon, good evening to all of you. This is our monthly case, and I'm delighted to have my great friend and brother Ernesto Guerra from Barcelona. I'm sitting here in Istanbul with the beautiful picture of Ataturk behind me. So we are going to discuss a case that I did here in Istanbul. Ernesto, welcome to the live case discussion. Thank you for being here, my friend.
It's a pleasure for me, Jay.
Thank you.
Always is possible. Yeah, thank you.
And this case is just a practical case, nothing to catch people about, nothing surprising. Well, but there are some challenging lessons for all of us to learn. Here's a 67-year-old gentleman from Oman, had 6 previous operations, including a 2-stage exchange. He hasn't walked for 6 months, maybe longer. He has pressure sores developing on a sacral region. He's infected with Candida albicans. He's hypoalbonemic. He's also anemic, and this is his X-ray. So he's definitely still infected. His wound looks terrible. So what you agree that this is a challenging problem, Ernesto? Correct?
Absolutely, Jay. Absolutely. It's a very complex case. It's a tough one. Uh, Fortunately, the patient has ended under your care. Otherwise, he will have few opportunities to live to these catastrophic events. Yeah.
So the question is, what are the options for this patient? Many people would say just leave him with the resection arthroplasty, do nothing. He doesn't want that option, and he's getting very, very sick. He will most likely die if we don't ambulate him. Some will say, I will do a 2-stage exchange. The problem with 2-stage exchange is you would still leave him with a spacer in place for another 3 months or so. So I decided to do 1-stage exchange here. And I tell you why. I think there are some areas where I thought I could make a difference. You know, the mid portion where there's that cable right here,
Yeah.
there is a periosteal elevation, and he actually has an abscess in the middle of the femur. So I thought maybe if I can get to that abscess and try to clean this out, I would be able to reconstruct him. Do you agree there's a periosteal elevation in the mid femur where that cable is?
Yeah, it seems to be an hypertrophic cortis, probably secondary to the infection. The posterior part of the diaphysis of the femoris has a hypertrophy secondary to hyperreaction. It could be a collection inside
Yes.
the femur. Yeah, inside the
And
femur.
there is obviously, I know that because I opened them up. So we opened up and we actually did a direct transverse osteotomy of the femur in that area, cleaned it all out. And then, your options here are proximal femoral replacement, or I decided I wanted to use an uncemented stem. But before moving into any case, first stage or second stage, do you agree that we need to get the organism or make every effort to isolate the organism?
It's extremely crucial. It's extremely crucial. It is necessary to isolate identify the organism, probably due to his immunocompromise, probably due to several surgeries. There is the possibility that there is not only one microorganism, and we have to be sure if we are uh, getting the battle against one microorganism or multiple
Yes.
infections. Yeah,
How long
multiple
do you
generous
keep
infections.
how long do you keep the culture, Ernesto?
Uh, in not complex cases, it is enough 14 days,
Yes.
but in case of multiple reinfections, in case of immunocompromised host,
Yes.
it is necessary to prolong the culture time, probably to 4 or 6 weeks.
Okay. Yeah.
Probably, surely it is one of those cases.
Yeah, same here. We keep the culture for minimum 14 days. That's the recommendation of the
Yeah.
international consensus. And then if you're suspecting TB or something other than regular gram positives, you should keep it for longer. I completely agree. Now, interestingly, and I know you were part of the ICM, I was a little surprised with the answer to this question. The question asks if there are any absolute contraindications to performing a one-stage exchange for patients with chronic PJI. What are your thoughts? Are there any absolute contraindications?
Yeah, I know the recommendation of this question. It was very, very controversial. It is the conclusion was there was no any absolute contraindications, only in systemic cases, in systemic infections or immunocompromised, extensive soft tissue defects. It could be a relative contraindication, but it's according to the consensus, there is no any absolute
Absolutely. And this was
contraindication.
90% agreement,
Yeah,
Ernesto. I was super
90%.
surprised. Yeah, I was very, very surprised. But in any case, I think it's not a good idea to do one stage exchange in somebody who's systemically sick because you want to get in there and remove everything and then take the patient to intensive care unit. If there's massive soft tissue compromise, probably also that's going to be a very, very long operation. And then obviously a very severely immunocompromised patient. You could say that this patient is severely immunocompromised because he's anemic, he's hypoalpinemic,
Yeah.
but he didn't have a primary immunodeficiency. So I decided to proceed and do the one-stage exchange. Do you do one-stage exchange?
I started to do this one stage exchange 3 years ago, and I'm shifting from two stage to one stage. But probably due to the condition of these patients, I would do a two-stage exchange for this. Honestly, yeah.
Yeah, and I don't think that's the right answer. I'm not saying that doing a two-stage is a bad idea, but I decided to do one-stage exchange. And by the way, we did a one-stage exchange together almost 3 years ago in Barcelona. Do you
Yeah,
remember
but
the
it,
chronic knee
yeah,
patient
I
from
remember.
Egypt? Yeah. So we have a protocol. If you remember, we have a very, very strict protocol. Extremely important to do mechanical debridement. And then we do chemical debridement with 4 different antiseptic agents, half a percent hydrogen peroxide, 0.125% hypochlorite, 0.5% povidone iodine, and I also scrub the implants and the tissues with 4% chlorhexidine. Those scrubs. I did
Yeah,
one stage exchange today, actually, in Istanbul, and that's exactly what we did. So I start with the 4% chlorhexidine, wash that out, then do half a percent hydrogen peroxide, wash that out. Then I do the Dakin solution, which is 0.125% hypochlorite, and then my final solution is povidone iodine. I do rescrub. I do take things down and then put a new
set
um,
up. Yeah.
what about local delivery, Ernesto? What are your thoughts about local delivery of antimicrobial?
According to the international consensus meeting, there is an important role of local antimicrobial carriers with calcium sulfate
Yeah,
or hydrogel. We have a lot of experience. I have a lot of experience with calcium sulfate, concretely the stimulant.
yeah.
Uh, for carrier, for vancomycin and gentamicin, it is reabsorbed in around 4 to 6 weeks. There are some colleagues that use the hydrogel, but the evidence shows that there is more strong evidence regarding calcium sulfase, and honestly, is what I used. We can
Yeah,
target the sensitivity of the microorganism also, adding the
and the
antimicrobials
antimicrobial.
to the calcium sulfate. Yeah.
Yeah, so I actually prefer to leave a catheter behind, like here, either a Hickman catheter or regular drain, and then I inject them once a day with a local antimicrobial. I actually learned that from Shaoli in
In
China,
China, yeah.
and they did this analysis for the consensus, and if you see, there's like a huge number of different ways to deliver antimicrobials, including the absorbables that you talked about. And I actually did a case with him. I scribed in a case, fungal case, very, very complex case. And he did this and he left the catheter behind for the delivery. So what about after surgery in one stage? How long do you give antimicrobials? This was a question, as you know, during the consensus. And at the moment, they're talking about minimum of 6 weeks, probably 3 months. Do you agree with that thought process?
Probably, if we gather 10 orthopedic surgeons, we will not agree any other one regarding the duration of the antimicrobial therapy and the route also. In Europe, is only 2 weeks of parenteral and antibiotics, and in America, there are 6 weeks of IV antibiotics and then 6 months of oral antibiotics, according to the last RCT of one stage versus two stage.
Comparing, yes, we will
Yeah,
talk
yeah,
about that in a second. But I think minimum 6 weeks. I
yeah.
personally think 12 weeks is probably optimal. I wouldn't give 6 months, but I'll tell you in a second why that was 6 months in the US trial. But 12 weeks, either oral or intravenous. There are some organisms that you can treat with the oral antimicrobials. And fungus is one of them. You can certainly give a fungal antifungals orally. But one of the most important things is that during one stage or even two stage, you have to make sure that we absolutely do extensive debridement. And as George Searney used to say, you have to operate on these infected cases like you're operating on tumor. Do you agree?
Absolutely. Let's remember another phrase that used to say George Ciarni. He used to
Yes.
say that if your surgery is going to take more than 4 hours, you must close and get back later. So the surgery that you do, it should be expeditious, rapid, aggressively to the infected tissue, soft tissue, bone infected, do an expeditious surgery. And
Yeah.
in the case of one stage, the implantation should be done before the 4 hours, or otherwise do a two-stage exchange.
Yeah. Yep. So here we did a aggressive debridement, extremely thorough mechanical debridement, followed by chemical debridement. He had very obviously angry soft tissues because he's had 8 prior operations. And I use negative pressure wound therapy. What do you think about that?
Yeah, it's the best indication to treat the soft tissue and avoid persistent wound leakage, and to better treat the deep space. These dressings, although it will be preferred, especially in this case, the prevenient type of wound therapy, because it takes, I think that it manage better the dead space from beyond the dead space that is deep in the
Yeah.
surgical area,
Yeah,
but
so negative
it
pressure
works
wound
very.
therapy
Yeah,
for complex incisions like this is definitely a great idea. We leave that in for 7 to 14 days.
yeah,
This is his gait the next day. As I told you, he hadn't walked for at least 6 weeks, maybe longer. This is how he's walking now. First day. Then we send him to a robotic machine where They're working on his muscles on a daily basis.
Oh, that's
And this is
nice.
his latest X-ray, latest gait, which I believe he's now about 3 months out from his surgery. So he walked well. Now, there are a lot of randomized, well, there's a lot of data now on one stage versus two stage. The first one is that informed trial that came out of England and Switzerland and Sweden. This was not powered to look at the difference between one stage versus two stage. Primary outcome was really WOMAC, but secondary outcome was, of course, cost effectiveness, recurrent infection, and complications. And then, as you're aware, the results were the same for one stage versus two stage, right?
Yeah.
So this
Regular
was the
infection,
first
yeah.
study. And then, of course, one stage is cheaper and patients prefer one stage. And then this is the study that you mentioned. Tom Ferring should be congratulated for running this study that just got published in JBJS. It took us a very, very long time to do this. And this trial is what you were saying, 6 months of antibiotic treatment after both one stage and two stage. We chose the 6 months because that's what the IRBs and the ethical approvals were asking us to do, because there wasn't enough data on result of one stage exchange. That's why this protocol was aggressive with the oral antibiotics. But as we talked about it earlier, honestly, I think 3 months is enough. What are your thoughts about
Yeah,
this trial?
the controversy regarding this trial is not only the 6 month of oral antibiotic, it is also the 6 weeks of IV antibiotics. What we used to do is to change from IV to oral at
Yes.
2 weeks after the surgery, once we have identified the microorganism, and if possible, it changed to the oral route. And for
Absolutely.
3 months probably, not in fungal infections, obviously.
But you're absolutely right. So you can do oral antimicrobials, and that was discussed during the consensus. You can
Yeah,
certainly do oral antimicrobials. You don't have to always give intravenous antibiotics. And the Oviva trial from Oxford that Matt
yeah,
Scarborough did shows that oral antimicrobials are effective. And we discussed that during the consensus. And a lot of the infectious disease doctors felt that we could do oral antimicrobials. You don't always have to give intravenous. You're absolutely right, especially with some of the sensitive organisms. And fungi also fall into that category as well, Ernesto. You could definitely give oral antifungals. But people, criticize all the literature on one stage versus two stage, saying, well, the one stage cases were cherry picked. The US trial, it randomized everything. There were MRSA patients. They were even, like one of the cases I included, had Mycobacterium abscessus. There was no cherry picking. The only thing we didn't include in the US trial is actually the fungal infections, because we didn't have enough data to know whether the fungal infections is okay or not. So the results were fantastic. Two
yeah.
stage and one stage had the same outcome. Were you surprised?
Another criticism to the study. Well, there were no cherry pickings, as you said, but there were five exclusion criteria. Uh, Culture negative infections, fungal infections, severe immunocompromised patients like yours probably, uh, previous revisions like yours, and when the soft tissue is not able to
To be
tolerate an
closed.
adequate closure. Yeah. Uh, so
Yeah.
there is not some. There are not too many complex cases, in the conclusion, you all the members of the study recommend to rigorous adhere to the indication of this rigorous protocol to have a high success rate of to cure the infection. Yeah.
Yes, and this one stage versus two stage was pretty much the same. So people say, well, I don't do one stage because I'm worried that it may fail. And then what am I going to do when it fails? Well, the answer is the same. What do you do when a two-stage exchange fails? Unfortunately, well-fixed components that get infected again are tough to take out. But if they get infected, which they do, 10, 15, 20% of two-stage exchanges get reinfected, you have to take them out and you have to consider another surgical option. And here the endo clinic results is fantastic. They had favorable outcome of a repeat one-stage exchange.
Yeah.
So one-stage exchange, I think, is, as you said earlier, is gaining popularity, certainly in Europe. Whether that will be the case in US or not, I don't know. But at this point, Europe is definitely leaning towards one stage. And one stage appears to have a fantastic result, which I think is wonderful. Any additional thoughts you want to share with us, Ernesto?
Yes, I will add that we should mention that it is necessary not only these tough cases, not only these complex cases that has been operated previously many times, including no so much complicated cases, infected implants patients should be treated in specialized centers
Yeah.
that has a multidisciplinary teams with microbiologists, infection disease doctors that are focused on musculoskeletal infections, experienced surgical team, not only the surgeon, obviously also the surgeons, but all the surgical teams should have experience treating these complex cases. Probably
What
that's a message from my part. Yeah.
very, very, very shrewd advice. Thank you for sharing that with us. I agree 100%. Especially complex cases like this should really be
Yeah.
treated in the specialized centers because of the reasons you mentioned. I can't thank you enough, Ernesto. I know you've had a very busy day today. You're in Barcelona, though, beautiful Barcelona. You have a fantastic time. I hope you'll have a great evening. I can't thank you enough for being with us, and I hope our listeners have enjoyed looking at this case together.
It's been a
Thank you
pleasure.
again.
Yeah. Thank you for the
Thank you
invitation.
so
And
much.
it's
Have a great day.
very
Thank
grateful.
you.
Thank
Bye-bye.
you.
Thank